You're listening to Health Innovators, a podcast and video show about the leaders, influencers, and early adopters who are shaping the future of healthcare. I'm your host, Dr. Roxy Mooney. Welcome back, Health Innovators. On today's episode, you're in for a real treat. We are hosting another executive briefing with some brilliant leaders and great colleagues and friends. Jeff Carlisle, the president of Pneuma Systems Corp., Howard Rosen, CEO and founder of LifeWIRE, and Brent Wright, the Associate Dean for Rural Health Innovation at the University of Louisville. Welcome back to the show, guys. So today we're talking about data, patient data, medical data. And so I want to just kind of kick off our conversation with what's the difference between good data versus bad data?
Well, in New England, of course, we refer to it as data. So,
is that good data or bad data?
Bad data. Yeah. I think one of the distinctions is the data doesn't really have any value unless it's been converted to information. And that conversion requires context, organization, includes, sorting and filtering and that kind of thing, and then analysis. So the bad data is stuff that doesn't ever get to actionable information. It's noise. Mm-hmm. But good data is, not favorable or unfavorable. It's just real information that's actionable. So if you have information that's not actionable, then it's also noise. But information is actionable, meaning it will change your behavior. That's what I would say is valuable data.
And the difficulty of that is it depends on who is utilizing the data, because you have different groups, as we talked about earlier in the pre-show, is the patient has a certain amount of data that's actionable and valuable for them versus the clinician versus the provider anywhere in that ecosystem, which complicates the matter. So what may bad data using the context of actionable for one group may be actually valuable and good for another.
Well, that's the context.
Why should this be easy?
Yeah.
Yes, absolutely. Yeah. Exactly. Because why should this be easy?
Okay. So what is, what's happening? Like, what do we do? Do we have a lot of data out there? Do we have a lot of information? What's happening today? And what are we expecting to happen in the future?
I think we're drowning in data. I think we suffer from data deluge syndrome. It's just, that's where data causes anxiety. We have so much of it, but we don't know how to put it together to bring forth information and knowledge to give us concept and allow us to act. Because that's the reason we have it in medicine. We want data so we can act on the behalf of the patient. That's what we want to do. But because data is in disparate sources and we don't have true interop to this day to allow us to bring a lot of information forward, we just don't have that. So it leads to a lot of frustration.
When medical errors happen and the quote record from an acute care facility is brought to court, it can be 6 feet high, right? Massive amounts of data. And in many cases, the injury that's caused to the patient could have been solved by a 3x5 card. It's not the amount that is our friend. The amount is our enemy. Really, really, really need to have kind of problem-oriented focus and distillation of data, and we don't. That's hard to get.
So is this something that you think machine learning and AI is going to help fix, because it's going to be able to help us process these gigantic data sets and pull out something that's meaningful?
I think it certainly helped to a certain extent, but there's so many sources of data. A simple one are just patients going on to Dr. Google. That's a source of data and a source of information that necessarily AI or machine learning is not going to help, because they're going to be going to their clinician or to the provider with that data set. Again, whether it's actionable or filtered or anything else, that just adds to the fire hose of additional data that Brent was talking about.
Mm-hmm.
And I think we have to be careful about the noise, that's generated from all of this. I mean, we just want clarity. If AI and machine learning can give us clarity, can take a lot of information and bring it to that single point of truth that we're seeking, I think that's wonderful. But if it's just going to generate more baggage, more noise within the system, it's very frustrating. I mean, but I think you have to back up here as you start talking about, terms such as AI and machine learning. You really got to get the data right. And I still think that we struggle in medicine to make sure we get, a diabetic known as a diabetic, where you can take 1,000, 10,000, 100,000 diabetics, where you can put that into these algorithms and get true knowledge coming forth. We still have dirty data. We still have a lot of dirty data out there, and systems that don't communicate well with one another. So we're still in many ways, while we're talking about such great tools that were mentioned here, such as AI, we still in healthcare, I think in the trenches, just struggle. I think, we joke, a few of us joke about how beautiful paper is. You can talk about paper as being archaic, but sometimes there's just a beauty of paper that you can do with a pen. I mean, you can make a mark on paper. You can create a quick diagram on paper that you can't do that for patients, within electronic medical records. So there's still a beauty there. You have to balance it, but really getting it right. That's where I'm looking for the true innovators to come forth. How do we really, not just data science, but merging that data science and data graphic work together to really help us as clinicians and patients.
Saying that there's nothing new under the sun, and we always, kind of come back to where we were. So maybe the future, right? The 2030 data is going to be back to paper, and we're going to, in 2030, we're going to say, remember the good old days when we had paper. Howard,
but to Brent's point in terms of the data, and we're talking about, it's also what is it you're collecting in terms of context. Like, for example, work that we've done with wearables. And I know this is shocking, but a number of the wearables were not very accurate. However, many of them were inaccurate 100% of the time in exactly the same way. So what we were doing is not measuring the data, but measuring the change in the data from those wearables. And that actually became valuable information when we saw that change. So it's not taking the main thing, but just look at the change, and the delta actually became a very valuable insight for clinicians who we work with. So it is, back to your point, it's what is it the data, how do you make it into information? Back to Jeff's comment, that's one way we actually took data that was not necessarily strong as it was, but made it information by just taking the measuring the change over time.
We touched on a previous call about the FDA, but if you were to understand that the information you collect in the clinical trial is very, very limited, it's artificially constrained. Patient population is very controlled, but the real power of the data comes in the post-market surveillance, when you've got patients of all kinds of comorbidities and different environments, and I mean, just a massive complexity. Yet, if you've got good data, then the clarity becomes, it's amazing, right? So I think AI is more interesting on a societal analysis than on an individual patient.
Yeah.
Brent, I doubt if you've ever seen a patient where you said, oh my goodness, I could have treated this patient so much better if I'd only had a computer helping them with the data. It just doesn't happen, because that's not the critically limiting factor. It's in the aggregate it is, but for an individual patient, it's really the thoughtful quality of the data that you need.
Mm-hmm. Yeah, it's that curation.
Absolutely. Or the incremental measurement over time to have some predictions about what may potentially happen with that patient. I think we've yet to see the potential of that type of predictive analytics on these data sets, on this real world evidence that we're talking about.
I think,
go ahead, Brent.
I think what you said there, I think, and to Howard's point on Delta, I think that's going to be wonderful to see is we get people more used to wearing, devices that collect their biometric data. I mean, we don't know what it's like to measure someone's heart rate over 10 years. We're going to know what that's like. in the years and decades ahead to see what type of subtle variability that exists that may show you, early hypertension, early AFib, predictability for a heart attack. I just don't think we've not had the ability to collect that data. And that's, coming back to the AI ML point, I think that's what's really exciting. I do have concern on how we've applied diligence to the data that's before us now. To me, we don't handle data well. If you move from locale to locale, hospital to hospital, how are we going to be able to gain insight from these large data sets that we really need?
Well, and I think in a lot of ways, COVID has made that data even more disparate because now we've got virtual care, right? We've got all of these remote patient monitoring, all these wearables, all of these different devices and to collect data that's outside of the traditional healthcare ecosystem. So it's even more siloed than ever before. And so I think the challenges that we've had previously with interoperability and creating some kind of centralized data set is maybe even exacerbated by, it's good for us to finally be able to collect this data of the person in the home instead of just in the treatment center. But then it creates another problem, I think, for us to figure out how are we gathering and integrating that data. What do you guys think?
Well, there's that part. And I just don't talk to aggregating all this data, but on the other side, each individual is different. So Brent, obviously, I'm sure you run into this all the time. So a heart rate from one patient is different from a heart rate for another as to as what their norm is. So yes, you're collecting and aggregating this data, but at the same time, you need to break it down to, I think it's called precision medicine, to the extent that each person is individual. So again, it's understanding their individual as opposed to saying, well, the population does X, so this is a situation. It's breaking it down to much more specific. Again, this is part of this gross fire hose of data, is each person's elements are going to be different from the next person.
If we can lower
complicates it.
If we can lower the cost of collecting some of the data, like, pulse oximeter 10 years ago was, $2,500 and now it's $25. And if we can do that kind of thing, it's very important. Somebody comes to the doctor and they have back pain and they go get an x-ray and they see a spinal abnormality. It's almost impossible not to jump to the conclusion that that pain is caused by that abnormality. But the abnormality may have been around for 15 years and be completely unrelated to the back pain. But getting baseline data and looking at changes is really valuable.
So Brent, earlier you mentioned a term, data biome. Tell us did you create that? Did you come up with that on your own? Where'd that come from? What does it mean?
Well, you caught me, Roxy. I did, I thought I created it right there on a comment that Jeff said. And then you caught me just now because is that you were finishing up that portion I was Googling. So I saw, went to Google real quick and I see that there's quite
You're Googling on the show?
I'm good.
I love it.
Busted. Well, I felt that question was coming, so I wanted to check because someone else would Google. And so
check yourself, huh?
I checked myself. So, yeah, someone's already got this data biome term out there, but, it's not that hard. It's data. You've got a lot of microbiomes, a lot of biomes out there, a lot of study. But if you think the way I would conceptualize a data biome, it's look at all the data that we would view like PHI, your standard medical record. And then you look at the biometric data, you look at all the wearables we have down and bring that in as another line of data. And then you look at genomic data, and then you look at consumer data. I had a discussion, someone reached out to me about rural health. And I'm like, really, when you start thinking about people's health, it's how you exercise. How many times have I said diet and exercise, and how many times have patients not listen to that? But when you really think about it, if you had some idea of like, okay, this is what you're really eating. These are the receipts. I see that you have like less than 1% of your monthly receipts in fruits and vegetables, in fresh fruits and vegetables, not canned. And then if you think about getting down to that consumer data and aligning that to give you context of everything that's going on, including social determinants of health, when I'm hearing a lot of people ask for social determinant data, you put that all together, then you start getting this. I really like the term data biome. While others can lay claim to it, I think we can use it here or approach it. And because that's what we're chasing. We want that comprehensive view of patients so we can treat them, because you can tell me you have two diabetics. I can have diabetic in room 1 and 2, but they're going to be different based on all of that contextual data around them.
So my doctor asked me, how many beers a day do you drink? And I said, well, 2. They said, really? How many beers a week do you buy?
That is the epitome of what we're
There's
talking
an
about
alignment
here.
there between the consumption and the acquisition.
That's right.
but actually, it's a great example, though. Back to Roxy, one of your comments was in terms of the data and the context of the data. It's also with all these things, how is the data requested or asked of the individual? Is it patient generated? Is it wearable related? Where does it come from? Because the context, what's being asked, just to your point, Jeff, is there may be 2 different answers. Mm-hmm. So it's, again, awareness of that becomes, well, why not add just another factor? But that becomes a factor in it all. And we'll determine whether it is good data or bad data in which it's actionable or not.
Yeah, and that passive data that cannot lie.
Right.
Versus, the qualitative data where it could be that we're lying or we just remember it very differently than the receipts show.
I remember not long ago that I went to a new doctor and they wanted me to fill out a paper record, which was just very difficult for me. It caused a lot of stress, in fact, for me to fill out a paper record. And they said, do you have any surgeries or illnesses to report? And I said, no, a couple. And by the time I finished filling out the form, I said, can I have another sheet of paper, please? I had forgotten. Right? You just can't remember. And
No.
When we create medical records for people, which I've done on previous occasions, it actually takes months to get the record to be complete, because there's just so much family history, so many other related histories that you cannot remember on the fly. So it takes multiple iterations and literally months, which you can't compress into hours. It can't be done. You got to take calendar time to do it. So I think a perpetual, cumulative, patient-owned record that can always be audited and corrected, but never recreated. Right? You never try to remember your appendectomy. Right? It's always there. You can look at it and correct it, but that's really critical for medical record accuracy. If you look at a medical record for a hospitalized patient, it will be filled with uncorrectable errors. Some of them don't cause harm, but it is a ridiculous number of errors of omission and commission in any hospitalized patient's record.
Always. Yeah. So when we talk about this idea, Brent, that I'm going to just give you credit for, that you came up with, the patient biome, patient data biome, it sounds like a dream come true. So how far are we really from that reality? Are there any players in the marketplace that are either moving the needle or best suited to help us get closer to that full holistic aggregation of data?
Yeah, I think that, the term that comes to mind is PHR. It seems like there's an interest around PHRs. I mean, there's some noted failures out there early on. But if you think about how Apple came back with the tablet, I mean, the people were saying tablet was no more. And then here you come with the tablet and people like the iPad. I think, I don't know if I can give specific companies. I know people are working on it, and I want to be correct, but I don't know that anyone's out there doing it great or is going to get it. There's some big companies, they all want to do health data. I think the real question is, how do we get patients involved? I've always believed that patients are sometimes the last people thought about in healthcare. And we talk about how important it is to move data. Why doesn't the patient get some credit for data. Used to, we would bring glass bottles back to the grocery store and get credit for them. We get like a deposit on them. Why don't patients get some type of remuneration for agreeing to be, very liberal in sharing their data, whether that's for research or other causes? And I think that patients for a lot of years, as long as I've been practicing, and I've been practicing 20 years now, it's hard to believe I'm saying that, but even in the early days when I thought a universal record was coming like within 5 years, that patients still at that time, they thought that medicine had everything. They thought that healthcare has everything. They're like, you just have it in a computer, or you just have it there. There's this belief among patients that we have all their data perfectly, much like a credit report, like an Experian, TransUnion, Equifax. I think we're going to have to look at that model. Personally, I don't believe in interop anymore. I don't think we're going to get interoperability. I think interoperability is going to come through some other mechanism. And that mechanism is going to look like the credit reporting bureaus, because actually their philosophy is correct.
I think interoperability can come by having the focus of the information, the ownership of it, with the patient. So you're not trying to get a lot of different caregivers to seamlessly exchange information. What you're doing instead is really allowing a patient, and I don't say this lightly because I know the patient needs help in doing it. The patient can't manage their own medical record any more than you can manage your own taxes, right? So it's too complex. Not that it's complex, but it's more complex and specialized than any patient will want to do. But if you have that assistance, that paid for, monetized kind of assistance to help organize your record, and it's easily transferable to your next caregiver, whoever it is and wherever it is, that gives you the kind of interoperability, as long as there's an agreed upon structure. And today's structures, the continuity of care record and ASTM 31 and all that stuff, that doesn't really do the job. It's too complex, yet it's too simple. There's, I think, a better structure, but the more important thing isn't the structure of the data as much as it is the ownership of it.
And the ownership will drive the interoperability, to your point, Jeff. If all the patients own their data, the system itself will be forced to go, oh, if we want this data, we're going to have to actually create this universal interoperability. So it becomes a demand push. If you want to be in business, you have to find a way of actually being able to read that data.
Hey, it's Dr. Roxy here with a quick break from the conversation. Are you trying to figure out what moves you need to make to survive and thrive in the new COVID economy? I want every health innovator to find their most viable and profitable pivot strategy, which is why I created the COVID Proof Your Business Pivot Kit. The Pivot Kit is a step-by-step framework that helps you find your best pivot strategy. It walks you through 6 categories you need to examine for a 360-degree view of your business. I call them the 6 critical pivot lenses. As you make your way through this comprehensive kit, you'll be armed with the tools, tips, and strategies you need to make sure you can pivot with speed without missing out on critical details and opportunities. Learn more at legacy-dna.com/kit.
I want to go back to something that you said, Brent, about the credit bureau. Talk a little bit more about that and that comparison that you're making.
Okay, so I think it's really interesting if you look at banks and you look at sharing information about, let's say, loans to TransUnion, Experian, Equifax. You upload that information. They do that for free. They do that. And why do they do that? Why do they push that information to those bureaus? Is because that they know that they have safer lending universally throughout the financial system, because that is shared through those 3 bureaus. Those are the main ones. So why not in healthcare? Why don't we have that sharing? Because it's better if we share the information about patients and about knowledge, about research. The demand for clinical trials, as I understand it, I'm not a primary researcher, but those that I know who do research and promote clinical trials shake their heads. I mean, even at larger universities, it's just expensive to enroll. It's expensive to conduct. It's very challenging. for universities. Just think what we have now, the data collection tools at our disposal, whether it's a biometric device or our phone, and what, if patients own their data and said, look, if imagine getting a text message that you qualify for this study, you can enroll in this study for $100. Would you release your healthcare information from this app? Click, release your healthcare information. All of a sudden, boom, you're enrolled. Boom, you're enrolled. Boom, you're enrolled. And we've got the information's there, and healthcare has amnesia when it comes to patient data, because at every point of care, you redo that work all the time.
So annoying.
But
I mean, here we are 2021, and we're still filling out the paper chart every time.
Yeah, you don't want to cause harm with the data. And one of the things that causes harm is the request for re-entry of data, which is just an opportunity for a transcription error. You never want to re-enter data. You want to confirm it, edit it, check it off, sign it, initial it, whatever you want to do to review it. But you really should never allow data to be re-entered. The other data point is that you should avoid excess specificity. Right? We went from a billing system of ICD-9 codes to ICD-10, and there was never really even a theory as to how that could help anybody. It forced people to go to computerized billing. So it helped that industry, but no one else, because the artificial specificity actually caused harm.
I say you just can't argue with that.
No, it's like drop the mic.
Well, yeah, it's and that's part of the problem. Is it's this forced innovation. Well, we got to show we're innovative, we're making changes, but sometimes, to get Jeff's point, if there's no basis for that except change for the sake of change, you can create more harm or more confusion, or again, particularly in the transfer of information between the two systems. It's hard to see the good. Just change for the sake of change is not necessarily good change.
Yeah, can you imagine if someone decided we were going to have 100 commandments instead of 10?
Well, and you guys touched on the patient being the person that owns the data, and them being the ones that are kind of determining how it gets integrated and who it gets integrated with. And, kind of like the tax prep. And, what comes to mind is really almost that role being of the caregiver. Now, maybe there's not always an official caregiver involved, but, a lot of times we're talking about really sick people that aren't going to necessarily be that tax prep person. But a lot of times the caregiver, just in the whole effort of being an advocate for their loved ones, ends up becoming kind of that tax prep person that needs to be responsible for aggregating all of that data and then determining who gets it.
And that becomes tricky, because we went through that with my in-laws as they're getting older. Is you become that advocate, but what prep have I had? What education have I had? To become that, or my wife and I become that advocate. We're sort of put in that position. And so you're making, so there's a lot of these decisions being made. Yes, there's patient ownership, and it comes down to, okay, well, what do you know about what should be transferred, or what elements of this are valuable or not valuable? So I have told people that by education I have an MBA, and I said M now stands for medical, just because of all these things I had to do, and forced to be in. Now, I don't think it's accredited anywhere, but I kept on trying. But we're forced to, and as we get more of these sandwich generations, and we're caring for our parents as that example, that we're becoming those caregivers. We don't have the education, but all we do is you go online. Is what we did. Talk to a few people. Now is all we can do. So again, because it goes back to the context. You've got all this data. What's the proper context, and what's the valuable context that we have that can actually make those decisions? It's certainly not a black and white scenario.
Yeah, I think you've got aggregating, and then you've got navigating, where the caregiver comes in. And then I think you've got decision support. And I think that's where autonomy comes in, because in healthcare, we still have to abide by patient autonomy. And I think as people have more tools at their disposal, I think if we can show them how their data can give them greater opportunity around the knowledge of what's going on with them, around the potential consequences of their disease or the outcomes or the treatment algorithms. I think that people can make use of those, but they're going to have the user experience correct. And again, they will not work well if you don't have good data going into them. And I think rather than healthcare systems be worried about that, I think they're going to have to use those with patients, because I think this whole thing around data and data blocking and not sharing data, I think healthcare systems see that as the ultimate advantage, but that's going to go away. When it goes away, I'm not sure, but it is going to go away as patients have more control over their data. And I think you're going to find that patients still need their local healthcare systems as much as they always have. Oh, yeah. And trying to get past that fear is going to be, I think, a big leap for data integration.
Brent, how about a baby step where today, if you go to Quest or LabCorp, you'll get your blood analysis, and all the outlying values will be highlighted in red. And that's very, very helpful, right? It's extremely helpful.
Yes, it is.
But what if you also had a color coding or some other indication of how it shifted, even if it's in limits, within limits or out, how it shifted over time, right? So you got the patient became the normal value set, and you're looking at exceptions. So you can look at, clinical exceptions, obviously, for all mammals or whatever you want to look at. But in addition, getting the benefit of trend for that individual patient.
Yeah, I think those tools are going to be great in getting people accustomed. I think if you look at some basic biometrics like walking, like step counters, things like that, I think it really is. I mean, I think this is where the counterintuitive play comes in for success in healthcare innovation. I think you've got to have the science, and I think you have to have the artist come together, because people are going to engage as they have a very rich infographic experience. If you show me my data in an Excel spreadsheet, that's boring. If you show me, my data with color and maybe bubble charts or something that really gives me more of an insight and more of an engagement with my healthcare data.
Some gamification sprinkled in.
Yes. Yeah. And then maybe, look, you're doing great. Oh, by the way, Humana just sent you a note. Anthem just sent you a note and said, you're doing so great that they're gonna, you're gonna get this. I mean, maybe you're gonna get a water bottle or a baseball cap, or maybe you're gonna get $5 off your premium or something. I mean, there's different tools out there, but I think people, I think, to your point earlier, Jeff, you talked about the money, how you install systems based on the money. And I think that's where healthcare systems are. We talk about treating patients and the virtue of treating patients, but at the end of the day, you usually are leading based on the economics. And then the humanistic aspect of the patient care and the physician care and the provider care are sometimes secondary based on how quickly you can get the economic installation in. So I think we have to bridge that and think about more how we engage to get better outcomes.
So who's responsible for educating consumers about the role that data plays in their healthcare, in their family, and the rights that they have to ownership and even potential compensation?
Well, I think, and add an element to that, and not that I necessarily have an answer to your question, which is a very important question, is the data we've been talking about for the most part is sort of leaning a bit more to biologics. But you also have the mental health side of things, and to look at SDOH as well. When you look at data relating to financial records, to buying habits, to where you're driving, like all sorts of things that tie into the mental health side, which is a whole other set of data, which is considerably more complex, but deals on the mental health side. And so to your question, Roxy, how do you educate somebody when I would argue, and Brent, and hopefully you can tell me I'm wrong, we really don't have a handle on all that yet. We're just realizing you have all these data points, but I don't know if there's necessarily real handle on the effect all these things have, even on the healthcare system, let alone the individual for making those decisions.
Mm-hmm. Well, and you think about the amount of data, just consumer data that we provide to, let's say, Facebook or Instagram, or even just Google based upon our Google search, right? Or our Google Maps or Apple Maps, right? There's just so much data that these other entities are collecting that can be used against us in harmful ways, whether we realize it or not. And we have a very different conversation about keeping that information private or disclosing that information, allowing these tools to have full access to it versus our healthcare data that, in some ways is even more critical for it to be managed well.
I think the patient privacy stuff is, I think, according to most patients, a little bit overblown, because there are very few medical anomalies that you have that aren't obvious to people anyway. I mean, I guess there are some people are walking out seemingly healthy, but, secretly morbidly obese, or, seemingly healthy, but with a broken leg. A lot of it is not secret, right? A lot of it is pretty obvious. They may not know exactly what you have, but they know if you're sick or not. But I think patient privacy is certainly an impediment to innovation in healthcare management.
I think in your question, Roxy, you asked, who educates consumers, and I think using the term consumers is very important here, because as I've gone along in my career, I've opened up my view of healthcare, and I've come to the realization now that healthcare is everyone's responsibility. Whether you have a health illness, healthcare is still going to affect you in some form or fashion. And anyone who can tell me how it's not, I would love to know, because whether that's in your investment account, whether it's in your taxes, whether it's in your family, I mean, you're going to be affected by healthcare and how healthcare is utilized and how people treat their health. And we've got a long way to go if you think about where we are right now with
yes, we do.
Pandemic and how people are looking at health and healthcare and science, and the lack of scientific literacy that we're seeing around how we're just dealing with one issue. And it's not like we cured cancer and obesity and cardiovascular disease and all of that, and now we have COVID on our plate. We've sort of forgotten about all of the chronic diseases as we deal with this most immediate threat that we're seeing through COVID. So I think everyone has an obligation in educating consumers, and I would like to see more, whether it's retail space or whether it's a large online retailer or an in-store retailer to work innovatively to think about how they can interact with patients' health. Because again, go back to diet and exercise. I think we need to rethink those. I think just, maybe a hackathon on those would be really good. How can we rethink how to inform people on what they're doing?
So I'm going to call out all the billionaires out there, Jeff Bezos, the trillionaire out there, trillionaire before COVID. I don't even know what you call it now after COVID, that needs to grab a hold of this mission and invest some dollars in this, because I agree with you. I think that every person in the world can benefit from this type of education and greater literacy. So we talked about a lot of different layers around data and patient data. As we think about the purpose of this show and the audience of the, our listenership and viewership, how does this conversation that we've had today affect those innovators that are in the marketplace today that are bringing innovations to market, or maybe even those people who, are playing some role in the innovation ecosystem?
I think every device or every invention has got some element of information to it. Perhaps not everything, but in the most part, it does. And you just have to be thinking about your invention in the context of a much, much bigger ecosystem. It's no longer okay to think about segregated data. So I think that's the big thing. You could get away with it, 10 years ago, but today, you've got to figure out how you play, in the Internet of Things and the Internet of medical information So I think that's the bigger thing. Think more broadly about where the information is coming from, where does it have to go, and how do you fit into a holistic picture.
Yeah, I think the use within the ecosystem is really important because, as I said, as we talked about earlier, there's many elements in that ecosystem, and the different data points may have different value along the way. So it's going to be really aware of all that, and the fact it's going to be used. And if it's collected, it's going to be potentially used and could be misused, not necessarily intentionally, but just misused. You got to be aware, so make sure it's contextualized and processed in a manner that is usable and understood along the way.
Mm-hmm.
You know, I've come to this and looking at data and what it means, and I think it all boils down to prediction. I think at every data point, insight, knowledge, however you want to frame that, I think ultimately people who are really playing the big data game are looking towards prediction. Everything that how did that predicts your next site, your next click, your next movement, and in medicine, it's your next heart attack or your next visit. Or I think that really thinking about how you use data for predictive capabilities, because I think that is one of the core areas. I think that's the reason I believe it to be important, is because I think the quest for prediction drives value.
Incredible value. Yeah. So I've, have a different guests on the show all the time. And there's a couple that come to mind when I hear you describe that, Brent. So one of them in particular is doing some prediction around bone density and the propensity to fall. And so kind of looking at early interventions of people, the cost to the healthcare system once they fall, the cost to that family and that quality of life. Mm-hmm. And so that would be just one really, example that comes to mind really quickly of how this is, data being used in a real positive way, in a real valuable way, not just for the sake of data right. In that type of prediction. Or you think about heart attacks, right? All of the different indicators that could potentially predict when someone's going to have a heart attack versus heartburn, and what are some interventions that could be at least presented, having that greater awareness. And
the I'm about to engage in some clinical studies for a new infusion pump, and the world today is very, very, very different than it was 10 years ago. So the FDA is looking for usability studies, but they're still thinking about a clipboard and somebody watching, a dozen nurses use their product. But what we're building in are, very sophisticated counters of behavior to find out, how many millisecond delay is there between this act and that act, and look at the big data aspects of it to find out where are people possibly confused, where are they hunting around, where did they make a mistake, or, where did you let them make a mistake? So it's a very different world in terms of information management than it was even 10 years ago.
And that goes to the point. It's just there's so much data. A lot of it, we don't even know what kind of data that we really have. Like we know sort of specific points of data. Just an example is we collect data as a communication platform. An element of data that we realized, again, in the mental health side, is not just the timestamp of when someone responded to a message, but we're measuring how quick someone does respond to a message, whether it's email, text, or whatever the case may be, and back to the change in the speed at which they change, or it takes them longer and longer and longer. Again, we've realized that becomes an indication of a change in behavior and working with the condition, what that change is. But that was a data point that resulted because of collecting data points. So I said, so within all that data, there's new data points of collection to explore that could be invaluable for the management and the decision support.
So any closing words as we wrap up here, when we kind of wrap up this conversation around data?
Well, the big theme is patient-centered data that's so much more holistic than we had ever imagined a short time ago. Right? It's all the stuff that Brent talked about in the biome, and it's becoming easier and easier to do it. So I'm actually hopeful that that kind of data will be available. Because the speed with which we can do things now and all the financial transactions is instantaneous. And there's really no technical reason why we can't be doing the same thing in healthcare.
And my only comment is when looking at the patient and data is we talked about earlier, is looking at the patient as a consumer. Mm-hmm. So in terms of as a perspective, I think that helps understanding the data and the value of the data and the need for the data at the patient side onward. But I think until everyone recognizes, you're hearing it more and more, but I think until the entire ecosystem recognizes it, you're still going to have some of these stopgaps. Once it's all recognized, then okay, at least we're moving towards solution to managing all this.
I think as this new patient consumer moves forward in healthcare and moves forward within the entire ecosystem, whether it's healthcare or commerce, I think that what we really need to happen is ubiquity. We really want this data ubiquity around individuals so we can get the best from our life. I mean, I think that sounds somewhat cliche, but that's really, I mean, a lot of healthcare is oftentimes seen as just being a moment of trial, a moment of sickness or illness. But I think that we're going to have to change the paradigm around how we view health and health data to make sure we are adapting every day to our best wellness. And that's going to be an exciting time. And that's where some great tools are going to be able to be used and implemented. But ubiquity for me, that's where we want to drive around data. And that's where we're going to see some exciting things advance.
So I'm going to close us out on this word that I think every innovator out there should go and poach a data scientist from a consumer goods company. Procter & Gamble, watch out for your data scientists, right? These are the folks that have been dealing with consumer data and understand how to leverage it in and out. And we could use some of those folks in healthcare and having, as innovators, whether we are a corporate innovator or we're a startup or academic innovator, thinking about our team and the teams that we're building and planning how that data scientist and when they fit into that role. Just like you would having a CEO, a president, a business development person, a marketing person, thinking about the role that data science plays on really, really early on in that business model. Well, thanks, guys. Thanks again for joining me. It was another great episode on the Health Innovators Show. Really appreciate your wisdom today.
Thank you.
All right. Thank you, Roxy.
Thank you so much for listening. I know you're busy working to bring your life-changing innovation to market, and I value your time and attention. To get the latest episodes on your mobile device automatically, subscribe to the show on your favorite podcast app like Apple Podcasts, Spotify, and Stitcher. Thank you for listening, and I appreciate everyone who shared the show with friends and colleagues. See you on the next episode of Health Innovators.